Chapter 5: Antipsychotic Agents. This chapter will explore antipsychotic drugs, with an emphasis on treatments for schizophrenia. These treatments include not only conventional antipsychotic drugs, but also the newer atypical antipsychotic drugs that have largely replaced the older conventional agents. Atypical antipsychotics are really misnamed, since they are also used as treatments for both the manic and depressed phases of bipolar disorder, as augmenting agents for treatment-resistant depression, and off-label for various other disorders, such as treatment-resistant anxiety disorders. The reader is referred to standard reference manuals and textbooks for practical prescribing information, such as drug doses. Because this chapter on antipsychotic drugs will emphasize basic pharmacologic concepts of mechanism of action and not practical issues such as how to prescribe these drugs, for that information see, for example, Stahl's Essential Psychopharmacology, the Prescriber's Guide, which is a companion to this textbook. Antipsychotic drugs exhibit possibly the most complex pharmacologic mechanisms of any drug class within the field of clinical psychopharmacology. The pharmacologic concepts developed here should help the reader understand the rationale for how to use each of the different antipsychotic agents, based upon their interactions with different neurotransmitter systems. Figure 5:1. Such interactions can often explain both the therapeutic actions and the side effects of various antipsychotic medications and thus can be very helpful background information for prescribers of these therapeutic agents. Conventional antipsychotics. What makes an antipsychotic conventional? In this section, we will discuss the pharmacologic properties of the first drugs that were proven to effectively treat schizophrenia. A list of many conventional antipsychotic drugs is given in Table 5:1. These drugs are usually called conventional antipsychotics, but they are sometimes also called classical antipsychotics, or typical antipsychotics, or first-generation antipsychotics. The earliest effective treatments for schizophrenia and other psychotic illnesses arose from serendipitous clinical observations more than 60 years ago, rather than from scientific knowledge of the neurobiological basis of psychosis, or of the mechanism of action of effective antipsychotic agents. Thus, the first antipsychotic drugs were discovered by accident in the 1950s when a drug with antihistamine properties, chlorpromazine, was serendipitously observed to have antipsychotic effects when this putative antihistamine was tested in schizophrenia patients. Chlorpromazine indeed has antihistaminic activity, but its therapeutic actions in schizophrenia are not mediated by this property. Once chlorpromazine was observed to be an effective antipsychotic agent, it was tested experimentally to uncover its mechanism of antipsychotic action. Early in the testing process, chlorpromazine and other antipsychotic agents were all found to cause neurolepsis, known as an extreme form of slowness or absence of motor movements, as well as behavioral indifference in experimental animals. The original antipsychotics were first discovered largely by their ability to produce this effect in experimental animals, and are thus sometimes called neuroleptics. A human counterpart of neurolepsis is also caused by these original, i.e., conventional antipsychotic drugs and is characterized by psychomotor slowing, emotional quieting, and affective indifference. D2 receptor antagonism makes an antipsychotic conventional. By the 1970s, it was widely recognized that the key pharmacologic property of all neuroleptics with antipsychotic properties was their ability to block dopamine D2 receptors. Figure 5:2. This action has proven to be responsible not only for the antipsychotic efficacy of conventional antipsychotic drugs, but also for most of their undesirable side effects, including neurolepsis. The therapeutic actions of conventional antipsychotic drugs are hypothetically due to blockade of D2 receptors, specifically in the mesolimbic dopamine pathway, figure 5 to 3. This has the effect of reducing the hyperactivity in this pathway that is postulated to cause the positive symptoms of psychosis, as discussed in Chapter 4, figures 4 to 12 and 4 to 13. All conventional antipsychotics reduce positive psychotic symptoms about equally well in schizophrenia patients studied in large multi-center trials if they are dosed to block a substantial number of D2 receptors there, figure 5 to 4. Unfortunately, in order to block adequate numbers of D2 receptors in the mesolimbic dopamine pathway to quell positive symptoms, one must simultaneously block the same number of D2 receptors throughout the brain. And this causes undesirable side effects as a high cost of doing business with conventional antipsychotics, figures 5 to 5 through 5 to 8. Although modern neuroimaging techniques are able to measure directly the blockade of D2 receptors in the dorsal, motor, striatum of the nigrostriatal pathway, as shown in figure 5 to 4. For conventional antipsychotics, it is assumed that the same number of D2 receptors is blocked in all brain areas, including the ventral limbic area of striatum known as the nucleus accumbens of the mesolimbic dopamine pathway, the prefrontal cortex of the mesocortical dopamine pathway, and the pituitary gland of the tuberoinfundibular dopamine pathway. Neurolepsis. D2 receptors in the mesolimbic dopamine system are postulated to mediate not only the positive symptoms of psychosis, but also the normal reward system of the brain, and the nucleus accumbens is widely considered to be the pleasure center of the brain. It may be the final common pathway of all reward and reinforcement, including not only normal reward, such as the pleasure of eating good food, orgasm, listening to music, but also the artificial reward of substance abuse. If D2 receptors are stimulated in some parts of the mesolimbic pathway, this can lead to the experience of pleasure. Thus, if D2 receptors in the mesolimbic system are blocked, this may not only reduce positive symptoms of schizophrenia, but also block reward mechanisms, leaving patients apathetic, anhedonic, lacking motivation, interest, and joy from social interactions, a state very similar to that of negative symptoms of schizophrenia. The near shutdown of the mesolimbic dopamine pathway necessary to improve the positive symptoms of psychosis, figure 5 to 4, may contribute to worsening of anhedonia, apathy, and negative symptoms. And this may be a partial explanation for the high incidence of smoking and drug abuse in schizophrenia. Antipsychotics also block D2 receptors in the mesocortical DA pathway, figure 5 to 5. Where DA may already be deficient in schizophrenia, see figures 4 to 14 through 4 to 16. This can cause or worsen negative and cognitive symptoms even though there is only a low density of D2 receptors in the cortex. An adverse behavioral state can be produced by conventional antipsychotics, and is sometimes called the neuroleptic-induced deficit syndrome, because it looks so much like the negative symptoms produced by schizophrenia itself, and is reminiscent of neurolepsis in animals. Extrapyramidal symptoms and tardive dyskinesia. When a substantial number of D2 receptors are blocked in the nigrostriatal DA pathway, this will produce various disorders of movement that can appear very much like those in Parkinson's disease. This is why these movements are sometimes called drug-induced Parkinsonism. Since the nigrostriatal pathway is part of the extrapyramidal nervous system, these motor side effects associated with blocking D2 receptors in this part of the brain are sometimes also called extrapyramidal symptoms, or EPS, figures 5 to 4 and 5 to 6. Worse yet, if these D2 receptors in the nigrostriatal DA pathway are blocked chronically, figure 5 to 7, they can produce a hyperkinetic movement disorder known as tardive dyskinesia. This movement disorder causes facial and tongue movements, such as constant chewing, tongue protrusions, facial grimacing, and also limb movements that can be quick, jerky, or coriform, dancing. Tardive dyskinesia is thus caused by long-term administration of conventional antipsychotics and is thought to be mediated by changes, sometimes irreversible, in the D2 receptors of the nigrostriatal DA pathway. Specifically, these receptors are hypothesized to become supersensitive or to upregulate, i.e., increase in number, perhaps in a futile attempt to overcome drug-induced blockade of D2 receptors in the striatum, figure 5 to 7. About 5% of patients maintained on conventional antipsychotics will develop tardive dyskinesia every year, i.e., about 25% of patients by 5 years. Not a very encouraging prospect for a lifelong illness starting in the early 20s. The risk of developing tardive dyskinesia in elderly subjects may be as high as 25% within the first year of exposure to conventional antipsychotics. However, if D2 receptor blockade is removed early enough, tardive dyskinesia may reverse. This reversal is theoretically due to a resetting of these D2 receptors by an appropriate decrease in the number or sensitivity of them in the nigrostriatal pathway once the antipsychotic drug that had been blocking these receptors is removed. However, after long-term treatment, the D2 receptors apparently cannot or do not reset back to normal, even when conventional antipsychotic drugs are discontinued. This leads to tardive dyskinesia that is irreversible, continuing whether conventional antipsychotic drugs are administered or not. Dopamine neurons in the nigrostriatal dopamine pathway make postsynaptic connections with cholinergic neurons, figure 5 to 11a. Dopamine normally inhibits acetylcholine release from postsynaptic nigrostriatal cholinergic neurons, thus suppressing acetylcholine activity there. Figure 5 to 11a. If dopamine can no longer suppress acetylcholine release because dopamine receptors are being blocked by a conventional antipsychotic drug, then acetylcholine becomes overly active. Figure 5 to 11b. One compensation for this overactivity of acetylcholine is to block it with an anticholinergic agent, figure 5 to 11c. Thus, drugs with anticholinergic actions will diminish the excess acetylcholine activity caused by removal of dopamine inhibition when dopamine receptors are blocked, figures 5 to 10 and 5 to 11c. If anticholinergic properties are present in the same drug with D2 blocking properties, they will tend to mitigate the effects of D2 blockade in the nigrostriatal dopamine pathway. Thus, conventional antipsychotics with potent anticholinergic properties have lower EPS than conventional antipsychotics with weak anticholinergic properties. Furthermore, the effects of D2 blockade in the nigrostriatal system can be mitigated by co-administering an agent with anticholinergic properties. This has led to the common strategy of giving anticholinergic agents along with conventional antipsychotics in order to reduce EPS. Unfortunately, this concomitant use of anticholinergic agents does not lessen the ability of the conventional antipsychotics to cause tardive dyskinesia. It also causes the well-known side effects associated with anticholinergic agents, such as dry mouth, blurred vision, constipation, urinary retention, and cognitive dysfunction, figure 5 to 10. Other pharmacologic properties of conventional antipsychotic drugs. Still other pharmacologic actions are associated with the conventional antipsychotic drugs. These include generally undesired blockade of histamine H1 receptors, figure 5 to 9, causing weight gain and drowsiness, as well as blockade of alpha-1 adrenergic receptors causing cardiovascular side effects such as orthostatic hypotension and drowsiness. Conventional antipsychotic agents differ in terms of their ability to block these various receptors represented in figure 5 to 9. For example, The popular conventional antipsychotic haloperidol has relatively little anticholinergic or antihistaminic binding activity, whereas the classic conventional antipsychotic chlorpromazine has potent anticholinergic and antihistaminic binding. Because of this, conventional antipsychotics differ somewhat in their side effect profiles, even if they do not differ overall in their therapeutic profiles. That is, some conventional antipsychotics are more sedating than others. Some have more ability to cause cardiovascular side effects than others. Some have more ability to cause EPS than others. A somewhat old-fashioned way to subclassify conventional antipsychotics is low potency versus high potency, table 5:1. In general, as the name implies, low-potency agents require higher doses than high-potency agents, but in addition, low-potency agents tend to have more of the additional properties discussed here than do the so-called high-potency agents, namely, low-potency agents have greater anticholinergic, antihistaminic, and alpha-1 antagonist properties than high-potency agents, and thus are probably more sedating in general. A number of conventional antipsychotics are available in long-acting depot formulations, table 5:1. Atypical antipsychotics. What makes an antipsychotic atypical? From a clinical perspective, an atypical antipsychotic is defined in part by the atypical clinical properties that distinguish such drugs from conventional antipsychotics. That is, atypical antipsychotics have the clinical profile of equal positive symptom antipsychotic actions, but low extrapyramidal symptoms and less hyperprolactinemia compared to conventional antipsychotics. Thus, they are atypical from what is expected from a classical, conventional, first-generation antipsychotic. Since almost all of the agents with this atypical profile came after the introduction of clozapine, sometimes the atypical antipsychotics are also called second-generation antipsychotics. From a pharmacological perspective, the current atypical antipsychotics as a class are defined as serotonin-dopamine antagonists, with simultaneous serotonin 5-HT2A receptor antagonism that accompanies D2 antagonism, figure 5-12. Pharmacologic actions in addition to 5-HT2A antagonism that can hypothetically also mediate the atypical antipsychotic clinical profile of low EPS and less hyperprolactinemia with comparable antipsychotic actions include partial agonist actions at 5-HT1A receptors and partial agonist actions at D2 receptors. Each of these mechanisms will be discussed here. In order to understand the mechanism of action of atypical antipsychotics and how this differs from conventional antipsychotics, it is necessary to have a somewhat detailed understanding of the neurotransmitter serotonin and its receptors. Thus, serotonin pharmacology will be discussed in detail throughout this chapter. Serotonin synthesis and termination of action. Serotonin is also known as 5-hydroxytryptamine and abbreviated as 5-HT. Synthesis of 5-HT begins with the amino acid tryptophan, which is transported into the brain from the plasma to serve as the 5-HT precursor, figure 5-13. Two synthetic enzymes then convert tryptophan into serotonin. Firstly, tryptophan hydroxylase, TRIO, converts tryptophan into 5-hydroxytryptophan, and then aromatic amino acid decarboxylase, AADC, converts 5-HTP into 5-HT, figure 5-13. After synthesis, 5-HT is taken up into synaptic vesicles by a vesicular monoamine transporter, VMAT2, and stored there until it is used during neurotransmission. 5-HT action is terminated when it is enzymatically destroyed by monoamine oxidase, MAO, and converted into an inactive metabolite, figure 5-14. Serotonergic neurons themselves contain MAO-B. which has low affinity for 5-HT. So much of 5-HT is thought to be enzymatically degraded by MAOA outside of the neuron once 5-HT is released. The 5-HT neuron also has a presynaptic transport pump for serotonin called the serotonin transporter, SERT, that is unique for 5-HT and that terminates serotonin's actions by pumping it out of the synapse and back into the presynaptic nerve terminal, where it can be restored in synaptic vesicles for subsequent use in another neurotransmission. Figure 5 to 14. 5-HT2A receptors. The key to understanding why antipsychotics are atypical is to understand the pharmacology of 5-HT2A receptors and the significance of what happens when they are blocked by atypical antipsychotics. All 5-HT2A receptors are postsynaptic, and 5-HT2A receptors are located in many brain regions. When they are located on cortical pyramidal neurons, they are excitatory, figure 5 to 15a, box 1, and can thus enhance downstream glutamate release, figure 5 to 15a, box 2. As discussed in chapter 4, glutamate regulates downstream dopamine release, so stimulating, figure 5 to 15a, or blocking, figure 5 to 15b, 5-HT2A receptors can therefore also regulate downstream dopamine release. Cortical 5-HT1A receptors also regulate downstream dopamine release, figure 5 to 15c, discussed below. 5-HT2A receptors are brakes on dopamine release in the striatum. 5-HT2A stimulation of cortical pyramidal neurons by serotonin, figure 5 to 15a, box 1, hypothetically blocks downstream dopamine release in the striatum. It does this via stimulation of glutamate release in the brainstem that triggers release of inhibitory GABA there, figure 5 to 15a, box 2. Release of dopamine from neurons in the striatum is thus inhibited, figure 5 to 15a. 5-HT2A antagonism cuts the brake cable. 5-HT2A antagonism of cortical pyramidal neurons by an atypical antipsychotic interferes with serotonin, applying its braking action to dopamine release via 5-HT2A receptors, figure 5 to 15b, box 1. Thus, 5-HT2A antagonism in the cortex hypothetically stimulates downstream dopamine release in the striatum, figure 5 to 15b. It does this by reducing glutamate release in the brainstem, which in turn fails to trigger the release of inhibitory GABA at dopamine neurons there, figure 5 to 15b, box 2. Release of dopamine from neurons downstream in the striatum is thus disinhibited, which should theoretically mitigate EPS. 5-HT2A receptors in other brain areas are also a brake on dopamine release in the striatum. 5-HT2A receptors theoretically regulate dopamine release from nigrostriatal dopamine neurons by additional mechanisms in additional brain areas. That is, serotonin neurons whose cell bodies are in the midbrain raphe may innervate nigrostriatal dopamine neurons both at the level of the dopamine neuronal cell bodies in the substantia nigra, figure 5 to 16a. Box 2, and at the dopamine neuronal axon terminals in the striatum, figure 5 to 16a, box 1. This innervation may be either via a direct connection between the serotonin neuron and the dopamine neuron, or via an indirect connection with a GABA interneuron. 5-HT2A receptor stimulation by serotonin at either end of substantia nigra neurons hypothetically blocks dopamine release in the striatum, figure 5 to 16a. On the other hand, 5-HT2A receptor antagonism by an atypical antipsychotic at these same sites hypothetically stimulates downstream dopamine release in the striatum, figure 5 to 16b. Such release of dopamine in the striatum should mitigate EPS, which is theoretically why antipsychotics with 5-HT2A antagonist properties are atypical. 5-HT1A receptors also regulate dopamine release in the striatum, figure 5 to 16c, discussed below. 5-HT2A receptor antagonism theoretically makes an antipsychotic atypical, low EPS. So, exactly how does this dopamine release by 5-HT2A antagonism reduce EPS? The answer to this is shown in figures 5 to 17 and 5 to 18. Normally, serotonin reduces dopamine release from the striatum by actions of serotonin at the various 5-HT2A receptors discussed above, figures 5 to 15a, 5 to 16a, 5 to 17. By contrast, the two actions of an atypical antipsychotic, namely blocking both D2 receptors and 5-HT2A receptors, are shown in figure 5 to 18, one at a time. On the left, D2 receptors are blocked by the D2 antagonist actions of the atypical antipsychotic, just like a conventional antipsychotic, figure 5 to 18a. If this were the only action of the drug, there would be EPS if occupancy of D2 receptors reached 80% or more, figure 5 to 18a. This is exactly what happens with a conventional antipsychotic. However, atypical antipsychotics have a second property, namely to block 5-HT2A receptors, which as discussed above have multiple mechanisms by which they increase dopamine release in the striatum, figures 5 to 15b, 5 to 16b, 5 to 18b. The result of this increased dopamine release is that dopamine competes with D2 receptor antagonists in the striatum and reduces the D2 receptor binding there below 80% to more like 60%. Enough to eliminate extrapyramidal symptoms, figure 5 to 18b. This is the hypothesis most frequently linked to the explanation for the mechanism of the most important distinguishing clinical properties of atypical antipsychotics, namely low extrapyramidal symptoms, EPS, with comparable antipsychotic actions. 5-HT2A receptor antagonism theoretically makes an antipsychotic atypical, low hyperprolactinemia. How do 5-HT2A antagonist actions reduce hyperprolactinemia? Serotonin and dopamine have reciprocal roles in the regulation of prolactin secretion from the pituitary lactotroph cells. That is, dopamine inhibits prolactin release via stimulating D2 receptors, figure 5 to 19, whereas serotonin promotes prolactin release via stimulating 5-HT2A receptors, figure 5 to 20. Thus, when D2 receptors alone are blocked by a conventional antipsychotic, dopamine can no longer inhibit prolactin release, so prolactin levels rise, figure 5 to 21. However, in the case of an atypical antipsychotic, there is simultaneous inhibition of 5-HT2A receptors, so serotonin can no longer stimulate prolactin release, figure 5 to 22. This mitigates the hyperprolactinemia of D2 receptor blockade. Although this is interesting theoretical pharmacology, in practice, not all serotonin dopamine antagonists reduce prolactin secretion to the same extent, and others do not reduce prolactin elevations at all. 5-HT2A receptor antagonism theoretically makes an antipsychotic atypical, comparable antipsychotic actions. Why doesn't 5-HT2A antagonism reverse antipsychotic actions? Although a conventional antipsychotic can only decrease dopamine, and will do this at D2 receptors throughout the brain, atypical antipsychotics with their additional 5-HT2A antagonist properties have much more complicated net actions on dopamine activity. Since they not only decrease dopamine activity by blocking D2 receptors, but they can also increase dopamine release and thus increase dopamine activity by indirectly stimulating dopamine receptors. However, these actions seem to be very different in different parts of the brain. In the nigrostriatal dopamine pathway and in the tuberoinfundibular dopamine pathway, there is sufficient dopamine released by atypical antipsychotics to reverse, in part, the unwanted actions of EPS and hyperprolactinemia. This does not appear to occur in the mesolimbic dopamine pathway, as antipsychotic actions of atypical antipsychotics are just as robust as those of conventional antipsychotics. Presumably due to regional differences in the way in which 5-HT2A receptors can or cannot exert control over dopamine release. The trick has been to exploit these differing regional pharmacological mechanisms to get the best clinical results by simultaneous blockade of D2 receptors and 5-HT2A receptors that can fortuitously have net blockade of differing amounts of D2 receptors in different areas of the same brain at the same time with the same drug. Although there are obviously many other factors at play here, and this is an overly simplistic explanation, it is a useful starting point for beginning to appreciate the pharmacological actions of serotonin-dopamine antagonists as a unique class of atypical antipsychotic drugs. The making of a therapeutic window. One way to display this phenomenon of the atypical antipsychotics' differing clinical actions is to contrast what happens to dopamine D2 binding in the striatum when a pure D2 antagonist is given. Figure 5-4. Versus when an atypical antipsychotic that combines equal or greater potency for blocking 5-HT2A receptors with D2 antagonism is given, figure 5-23. In the case of a pure D2 antagonist like a conventional antipsychotic, the amount of D2 receptor antagonism shown in figure 5-4 for the striatum is assumed to be the same amount in the limbic area and in the pituitary. This is why you get EPS and hyperprolactinemia at the same dose as you get antipsychotic actions. Namely, when all of these D2 receptors in all of these brain areas are blocked substantially. Many estimate this to be approximately 80%. There is little if any wiggle room between therapeutic actions and side effects, figure 5-4. However, in the case of an atypical antipsychotic, where essentially all of these drugs have an affinity for blocking 5-HT2A that is equal to or greater than their affinity for blocking D2 receptors, the amount of D2 antagonism in the striatum is lowered at the same dose where the drugs have antipsychotic actions. This creates a window between the dose that exerts antipsychotic actions and the dose that causes EPS or elevated prolactin levels, figure 5-23. While D2 receptors are assumed to be blocked by 80% in the limbic areas to cause antipsychotic actions, the D2 receptors in both the striatum and the pituitary are assumed to be blocked by only approximately 60%, below the threshold for side effects. Of course, if an atypical antipsychotic has its dose raised high enough, there will eventually be 80% blockade of even the striatum and pituitary, and the drug will lose its atypical properties. Thus, the drug is only atypical in the dosing window shown in figure 5-23. This window is created by the fact that atypical antipsychotics almost always have higher affinity for 5-HT2A receptors than they do for D2 receptors. You can visualize the relative receptor actions of atypical antipsychotics on 5-HT2A receptors versus D2 receptors by viewing simultaneously the relative potencies of the individual atypical antipsychotic drugs for binding 5-HT2A receptors versus D2 receptors, figure 5-24. The atypical antipsychotics can be categorized many ways, but for our discussion throughout this chapter, we will organize them as either the PINES, figure 5-24a, the DUNS, figure 5-24b, or 2 PIPs and a RIP, figure 5-24c. Specifically, The pharmacologic binding properties of each drug are represented as a row of semi-quantitative and rank order relative binding potencies at numerous neurotransmitter receptors. These figures are conceptual and not precisely quantitative, can differ from one laboratory to another, from species to species, and from method to method. And the consensus values for binding properties evolve over time. More potent binding, higher affinity, is shown to the left of the value for the D2 receptor. Less potent binding, lower affinity, is shown to the right. Since these agents are all dosed to occupy about 60% or more of striatal D2 receptors, figure 5 to 23. All receptors to the left OFD2 in figure 5 to 24 are occupied at the level of 60% or more at antipsychotic dosing levels. For these receptors to the left, there are also potentially clinically relevant receptor actions even at doses below those for treating psychosis. The receptors to the right of D2 in figure 5 to 24 are occupied at a level of less than 60% at antipsychotic dosing levels. Only those receptors that are bound by drug within an order of magnitude of potency of D2 affinity are shown to the right of D2. These receptor actions have potentially relevant clinical actions despite lower levels of occupancy than D2 receptors. With dwindling occupancy levels as the receptor is listed further and further to the right, and also when given at lower doses than normal antipsychotic dosing levels. The point is that although no two atypical antipsychotics have exactly the same pharmacologic binding profiles, it is easy to see that for the pines, figure 5 to 24a, and for the duns, figure 5 to 24b. 5-HT2A receptor binding is always to the left of D2 binding. This binding property of greater 5-HT2A than D2 binding potency is what is widely thought to make these drugs atypical antipsychotics and to create the window of atypical antipsychotic action that is theoretically linked to low EPS as well as to low propensity to elevate prolactin. Note that for 2 pips and a RIP, the 5-HT2A binding potency is to the right of D2 binding, and thus less potent than D2 binding, figure 5 to 24c. The fact that the 2 pips and a RIP are still atypical antipsychotics in their clinical properties is attributed to other actions. As will be explained in the sections below on 5-HT1A receptors and partial agonism of D2 receptors. Rather than having more potent 5-HT2A than D2 binding, as is the case for the pines and the duns. Binding at 5-HT1A receptors and partial agonism of D2 receptors may account for the atypical properties of the 2 pips and a RIP. 5-HT1A partial agonism can also make an antipsychotic atypical. In order to understand how 5-HT1A partial agonism can also reduce EPS, it is important to grasp how 5-HT1A receptors function in various parts of the brain, and how they can regulate dopamine release in the striatum. Postsynaptic 5-HT1A receptors in prefrontal cortex are accelerators for dopamine release in striatum. If 5-HT2A stimulation is the brake, stopping downstream dopamine release, figure 5 to 15a, and 5-HT2A antagonism, cuts the brake cable, enhancing dopamine release, figure 5 to 15b. What is the accelerator for downstream dopamine release in the striatum? The answer is postsynaptic 5-HT1A receptors on pyramidal neurons in the cortex. Figure 5 to 15c, box 1. 5-HT1A receptor stimulation in the cortex hypothetically stimulates downstream dopamine release in the striatum by reducing glutamate release in the brainstem, which in turn fails to trigger the release of inhibitory GABA at dopamine neurons there. Figure 5 to 15c, box 2. Dopamine neurons are thus disinhibited, just as they are by a 5-HT2A antagonist. This would theoretically cause dopamine release in striatum and mitigate EPS. Presynaptic 5-HT1A receptors in raphe are also accelerators for dopamine release in the striatum. 5-HT1A receptors can not only be postsynaptic throughout the brain, figures 5 to 15c, 5 to 16b, 5 to 16c, but also they can be presynaptic on the dendrites and cell bodies of serotonin neurons in the midbrain raphe, figure 5 to 25a. In fact, the only type of presynaptic 5-HT receptor at the somatodendritic end of a serotonin neuron is a 5-HT1A receptor, figure 5 to 25a. When 5-HT is detected at presynaptic somatodendritic 5-HT1A receptors on neuronal dendrites and on the neuronal cell body, this activates an autoreceptor function that causes a slowing of neuronal impulse flow through the serotonin neuron and a reduction of serotonin release from its axon terminal, figure 5 to 25b. Downregulation and desensitization of these presynaptic 5-HT1A somatodendritic autoreceptors are thought to be critical to the antidepressant actions of drugs that block serotonin reuptake. And this is discussed in Chapter 7 on antidepressants. When serotonin occupies a presynaptic 5-HT1A somatodendritic autoreceptor in the midbrain raphe, where they are located, figure 5 to 15c, box 2. Figure 5 to 16c, box 2, this turns off serotonin neurons. The serotonin pathways from raphe, figure 5 to 16c, box 2, to substantia nigra, figure 5 to 16c, box 2, and to striatum, figure 5 to 16c. Box 1, are thus off in the presence of serotonin at presynaptic 5-HT1A receptors. As a consequence, serotonin is not released onto postsynaptic 5-HT2A receptors on nigrostriatal neurons, activation of which would ordinarily inhibit dopamine release in the striatum, figure 5 to 16a. Lack of serotonin release due to stimulation of presynaptic 5-HT1A receptors thereby allows the nigrostriatal dopamine neurons to be active and thus to release dopamine in the striatum, figure 5 to 16c. Pre- and postsynaptic 5-HT1A receptors work together to enhance dopamine release in the striatum, and when both are stimulated by certain atypical antipsychotics, this theoretically mitigates EPS. Some, but not all, atypical antipsychotics have potent 5-HT1A partial agonist properties, figure 5 to 26. In particular, the two PIPs and a RIP, namely aripiprazole and the experimental antipsychotics brexpiprazole and cariprazine, all have 5-HT1A partial agonist actions not only more potent than their 5-HT2A antagonist actions, but comparable to their D2 antagonist actions, figure 5 to 26c. The 5-HT2A antagonist actions may also contribute to the atypical properties of these three agents, figure 5 to 26c. But the reduction of EPS for these agents is likely given a major boost by the additional presence of potent 5-HT1A partial agonist actions. In addition, note that potentially clinically relevant 5-HT1A partial agonist actions are present for a few of the pines, especially clozapine and quetiapine, figure 5 to 26a, and some of the duns, especially lurasidone, iloperidone, and ziprasidone, figure 5 to 26b, with those binding properties further to the left being relatively more potent and thus potentially more clinically relevant as well at antipsychotic dosing levels. The most dopamine release in striatum and fewest EPS may come when you take your foot off the brake and also step on the accelerator. If blocking 5-HT2A receptors is like taking your foot off the brake, and if stimulating 5-HT1A receptors is like stepping on the accelerator, this could account for why both of these actions that release dopamine from the striatum might be additive. It may also potentially explain why atypical antipsychotics with either potent 5-HT2A antagonism, Figure 5 to 24, or potent 5-HT1A agonist, partial agonist properties, Figure 5 to 26, or with both actions, have a reduced incidence of EPS. Thus, either pharmacologic action alone or both pharmacologic actions together seem to contribute to the atypical antipsychotic profiles of specific atypical antipsychotic drugs. Not only do several atypical antipsychotics have 5-HT1A partial agonist actions, Figure 5 to 26, but so do various agents with known or suspected antidepressant actions. From vilazodone to buspirone, augmentation of selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, SNRIs, to experimental agents with selective or mixed 5-HT1A partial agonism, e.g., vortioxetine. This has led to speculation that those atypical antipsychotics with 5-HT1A partial agonist actions that are proven antidepressants, such as quetiapine and aripiprazole, may be working in part through this mechanism, and that other atypical antipsychotics with 5-HT1A partial agonist actions are also potential antidepressants, such as brexpiprazole, cariprazine, lurasidone, iloperidone, and others. The mechanism of how 5-HT1A partial agonism exerts its possible antidepressant efficacy is unknown, but could be linked to release of dopamine and norepinephrine in prefrontal cortex or to the potentiation of serotonin levels in the presence of a serotonin reuptake inhibitor, which would be theoretically linked to antidepressant actions. 5-HT1B/D receptors. Presynaptic 5-HT receptors are autoreceptors and detect the presence of 5-HT, causing a shutdown of further 5-HT release and 5-HT neuronal impulse flow. Discussed above are the 5-HT1A presynaptic receptors at the somatodendritic end of the serotonin neuron, Figure 5 to 25. There is also another type of presynaptic serotonin receptor, and it is located at the other end of the neuron, on the axon terminals, Figure 5 to 27. When 5-HT is detected in the synapse by presynaptic 5-HT receptors on axon terminals, it occurs via a 5-HT1B/D receptor, which is also called a terminal autoreceptor, Figure 5 to 27. In the case of the 5-HT1B/D terminal autoreceptor, 5-HT occupancy of this receptor causes a blockade of 5-HT release, Figure 5 to 27b. On the other hand, drugs that block the 5-HT1B/D autoreceptor can promote 5-HT release, and this could hypothetically result in antidepressant actions. As for the experimental antidepressant vortioxetine discussed in Chapter 7, among the atypical antipsychotics, only iloperidone, ziprasidone, and asenapine, proven yet as antidepressants, have 5-HT1B/D binding more potent than or comparably potent to D2 binding, although many other agents have low potency at this receptor, Figure 5 to 28, including the proven antidepressants olanzapine, quetiapine, and aripiprazole. However, the link of 5-HT1B/D to the antidepressant actions of these agents, although plausible, remains unproven. 5-HT2C receptors. 5-HT2C receptors are postsynaptic and regulate both dopamine and norepinephrine release. Stimulation of 5-HT2C receptors is one experimental approach to a novel antipsychotic, since this suppresses dopamine release, curiously more from the mesolimbic than from the nigrostriatal pathways, yielding an excellent preclinical profile, namely, an antipsychotic without EPS. One such agent, the 5-HT2C selective agonist vavacacerin, has entered clinical trials for the treatment of schizophrenia. Stimulating 5-HT2C receptors is also an experimental approach to the treatment of obesity. since this leads to weight loss in both preclinical and clinical studies. Another 5-HT2C selective agonist, lorcaserin, is now approved for the treatment of obesity. Psychopharmacological treatments for obesity, including lorcaserin, are discussed in Chapter 14. Blocking 5-HT2C receptors stimulates dopamine and norepinephrine release in prefrontal cortex, and has pro-cognitive but particularly antidepressant actions in experimental animals. Several known and experimental antidepressants are 5-HT2C antagonists, ranging from certain tricyclic antidepressants to mirtazapine, to agomelatine, and these are discussed in Chapter 7 on antidepressants. Some atypical antipsychotics have potent 5-HT2C antagonist properties, especially the pines, including those with known antidepressant action, namely quetiapine and olanzapine, figure 5 to 29a. Olanzapine is often combined with fluoxetine to boost olanzapine's antidepressant actions in treatment-resistant and bipolar depression. Fluoxetine is not only a well-known SSRI, but also has potent 5-HT2C antagonist properties that may not only contribute to its antidepressant effects as monotherapy, but also add to the 5-HT2C antagonist actions of olanzapine when an olanzapine-fluoxetine combination is given. For quetiapine, there is some evidence for pharmacologic synergism between its norepinephrine reuptake blocking properties and its 5-HT2C antagonist properties. These two mechanisms can each boost dopamine and norepinephrine release in prefrontal cortex, something theoretically linked to antidepressant actions. This is discussed as well in Chapter 7 on antidepressants. Potent 5-HT2C antagonist action suggests theoretical antidepressant effects for asenapine, but there are only relatively weak 5-HT2C binding potencies for most of the other atypical antipsychotics. 5-HT3 receptors 5-HT3 receptors are postsynaptic and regulate inhibitory GABA interneurons in various brain areas that in turn regulate the release of a number of neurotransmitters. From serotonin itself to acetylcholine, norepinephrine, dopamine, and histamine. 5-HT3 receptors are also involved in centrally mediated vomiting and possibly also in nausea. Peripheral 5-HT3 receptors in the gut regulate bowel motility. Blocking 5-HT3 receptors in the chemoreceptor trigger zone of the brainstem is an established therapeutic approach to mitigating the nausea and vomiting caused by cancer chemotherapy. Blocking 5-HT3 receptors on GABA interneurons increases the release of serotonin, dopamine, norepinephrine, acetylcholine, and histamine in the cortex, and is thus a novel approach to an antidepressant and to a pro-cognitive agent. The proven antidepressant mirtazapine and the experimental antidepressant vortioxetine are potent 5-HT3 antagonists, and this may contribute to the antidepressant actions of such agents, especially in combination with inhibition of serotonin, norepinephrine, and/or dopamine reuptake. Antidepressant actions linked to 5-HT3 receptors and other serotonin receptors are discussed in Chapter 7 on antidepressants. Among the atypical antipsychotics, only clozapine has 5-HT3 binding potency comparable to its D2 binding potency, and the others have very weak or essentially no affinity for this receptor. So 5-HT3 antagonism does not likely contribute to the clinical actions of atypical antipsychotics. 5-HT6 receptors 5-HT6 receptors are postsynaptic and may be key regulators of the release of acetylcholine and cognitive processes. Blocking this receptor improves learning and memory in experimental animals. 5-HT6 antagonists have been proposed as novel pro-cognitive agents for the cognitive symptoms of schizophrenia when added on to an atypical antipsychotic. Some atypical antipsychotics are potent 5-HT6 antagonists, clozapine, olanzapine. Asenapine, relative to D2 binding, figure 5 to 30A, and other atypical antipsychotics have moderate or weak binding to 5-HT6 receptors relative to D2 binding, quetiapine, ziprasidone, iloperidone. Aripiprazole, brexpiprazole, figure 5 to 30A, B, C, but it remains unclear how this action contributes to any of their clinical profiles. 5-HT7 receptors 5-HT7 receptors are postsynaptic and are important regulators of serotonin release. When blocked, serotonin release is disinhibited, especially when 5-HT7 antagonism is combined with serotonin reuptake inhibition. This is discussed in further detail later in this chapter and also in Chapter 7 on antidepressants. Novel 5-HT7 selective antagonists are thought to be regulators of circadian rhythms, sleep, and mood in experimental animals. Several proven antidepressants have at least moderate affinity for 5-HT7 receptors as antagonists, including amoxapine, dizipramine, imipramine, mianserin, fluoxetine, and the experimental antidepressant vortioxetine. Several of the pines and duns are potent 5-HT7 antagonists relative to D2 binding, to the left of D2 for clozapine, quetiapine, and asenapine in figure 5 to 30A, and to the left of D2 for risperidone, paliperidone, and lurasidone in figure 5 to 30B. Other pines, duns, and the two pips and a rip have moderate affinities as well, to the right in figure 5 to 30A, B, C, which are potentially clinically relevant. It is plausible but unproven that 5-HT7 antagonism contributes to the known antidepressant actions of quetiapine, especially in combination with SSRIs, SNRIs, and in combination with its other potential antidepressant mechanisms discussed above for quetiapine such as NET inhibition, 5-HT2C antagonism, and 5-HT1A partial agonism. It is also plausible but unproven that 5-HT7 antagonism could contribute to the known antidepressant actions of aripiprazole, especially in combination with SSRIs, SNRIs, and in combination with its 5-HT1A partial agonism. This leads to speculation that lurasidone, asenapine, brexpiprazole, and others could have antidepressant potential in unipolar major depressive disorder, especially in combination with SSRIs, SNRIs, but more clinical trials are necessary at this time to prove this. Recent data already indicate antidepressant actions of lurasidone in bipolar depression. D2 partial agonism, DPA, makes an antipsychotic atypical. Some antipsychotics act to stabilize dopamine neurotransmission in a state between silent antagonism and full stimulation, agonist action by acting as partial agonists at D2 receptors, figure 5 to 31. Partial agonist actions at G-protein-linked receptors, which is how D2 receptors are categorized, are explained in Chapter 2 and illustrated in figures 2 to 3 through 2 to 10. Dopamine partial agonists, DPAs, theoretically bind to the D2 receptor in a manner that is neither too antagonizing like a conventional antipsychotic, too cold, with antipsychotic actions but extrapyramidal symptoms, figure 5 to 32A, nor too stimulating like a stimulant or dopamine itself, too hot, with positive symptoms of psychosis, figure 5 to 32B. Instead, a partial agonist binds in an intermediary manner, just right, with antipsychotic actions but no extrapyramidal symptoms, figure 5 to 32C. For this reason, partial agonists are sometimes called Goldilocks drugs if they get the balance just right between full agonism and complete antagonism. However, as we shall see, This explanation is an oversimplification and the balance is different for each drug in the D2 partial agonist class. Partial agonists have the intrinsic ability to bind receptors in a manner that causes signal transduction from the receptor to be intermediate between full output and no output, figure 5 to 33. The naturally occurring neurotransmitter generally functions as a full agonist and causes maximum signal transduction from the receptor it occupies, figure 5 to 33. Whereas antagonists essentially shut down all output from the receptor they occupy and make them silent in terms of communicating with downstream signal transduction cascades, figure 5 to 33. Partial agonists cause receptor output that is more than the silent antagonist, but less than the full agonist, figure 5 to 33, bottom. Thus, many degrees of partial agonism are possible between these two extremes. Full agonists, antagonists, and partial agonists may cause different changes in receptor conformation that lead to a corresponding range of signal transduction output from the receptor, figure 5 to 34. An amazing characteristic of D2 receptors is that it only takes a very small amount of signal transduction through D2 receptors in the striatum for a dopamine D2 receptor partial agonist to avoid extrapyramidal side effects. Thus, a very slight degree of partial agonist property, sometimes called intrinsic activity, can have a very different set of clinical consequences compared to a fully silent and completely blocked D2 receptor, which is what almost all known conventional and atypical antipsychotics do. Those agents all lie to the far left on the D2 partial agonist spectrum in figure 5 to 35. Partial agonists capable of treating schizophrenia lie far to the left on the D2 partial agonist spectrum, but not all the way to full antagonist. By contrast, dopamine itself, the naturally occurring full agonist, is all the way to the right on the D2 partial agonist spectrum in figure 5 to 35. Agents capable of treating Parkinson's disease, such as ropinirole and pramipexole, lie far to the right on the D2 partial agonist spectrum. What is so interesting is how very small movements off the far left and up the partial agonist spectrum in figure 5 to 35 can have profound effects upon the clinical properties of an antipsychotic. Just slightly too close to a pure antagonist, too far to the left, and it is just a conventional antipsychotic with EPS and akathisia unless it has other 5-HT2A, 5-HT1A properties that compensate for being too far to the left, comparable to too cold in figure 5 to 32A. On the other hand, just slightly too far to the right, and it is an atypical antipsychotic without EPS or akathisia, but one that is too activating, capable of worsening positive symptoms of schizophrenia and also causing intolerable nausea and vomiting, comparable to too hot in figure 5 to 32b. The elusive Goldilocks solution of a drug that is a tolerable high-dose antipsychotic without EPS and a tolerable low-dose antidepressant is being sought empirically by iterative introduction of a series of partial agonists, each differing in their intrinsic activity, that demonstrate the consequences of being either too close to the antagonist end of the spectrum or too far off that end of the spectrum. This is just a theory of how building tiny bits of partial agonism into a D2 antagonist can dramatically change its clinical properties, but there is some reasonable evidence for this possibility. Given that there are several agents with significant clinical testing or experience that are available and that have tested this pharmacological concept in patients with schizophrenia. For example, it is possible that the older agents sulpiride and amisulpride, not available in the US, are just barely off the antagonist part of the spectrum. Without sufficient 5-HT2A or 5-HT1A actions to forgive this, and thus have low but not zero EPS with robust antipsychotic activities at high doses. plus anecdotal but not well-tested antidepressant and negative symptom clinical actions at low doses, figure 5 to 35. Fairly extensive testing has been carried out of 5 other partial agonists shown in figure 5 to 35, with progressively increasing amounts of partial agonist action as they go from left to right. The first dart thrown at the partial agonist spectrum was OPC 4392, structurally and pharmacologically related to both aripiprazole and brexpiprazole, which were tested later. OPC 4392 landed too close to the agonist part of the curve, although it had relatively little intrinsic activity. This surprised investigators, who discovered that although OPC 4392 improved negative symptoms of schizophrenia, it also activated rather than consistently improved positive symptoms of schizophrenia. An imbalance did not have the profile of an acceptable antipsychotic, so was never marketed. However, investigators threw another dart closer to the antagonist part of the spectrum and it landed as aripiprazole. This agent is indeed an atypical antipsychotic in which the balance was improved so that it ameliorated positive symptoms without activating negative symptoms at higher antipsychotic doses, while proving to be an antidepressant at lower doses. Aripiprazole still has some akathisia, and some thought this was because it might be a bit too close to the antagonist end of the spectrum. Thus another dart, called bifeprinox, was aimed further up the spectrum, landing as more of an agonist than aripiprazole but less of an agonist than OPC 4392. Hoping for an improvement compared with aripiprazole, with less akathisia. What happened is that bifeprinox is too much of an agonist. It causes nausea and vomiting from dopamine agonist actions, and 5-HT1A partial agonist actions, and bifepronix's antipsychotic actions, although better than placebo, were not as robust as a full antagonist atypical antipsychotic, so the U.S. Food and Drug Administration, FDA, did not approve it. 2 more agents with antagonist actions greater than aripiprazole are in late-stage clinical testing, namely a second, PIP, brexpiprazole, and the RIP, cariprazine, figure 5 to 35. So far, both appear to have efficacy in schizophrenia, and clinical trials and dose finding in mania and depression are ongoing. But both agents, although having subtle pharmacologic differences, are looking as though they will have significant clinical differences not only from aripiprazole but also from each other. The takeaway point here is that D2 partial agonism can make an antipsychotic atypical, and that subtle changes in the degree of intrinsic efficacy along the partial agonist scale at the full antagonist end of the spectrum can have profound clinical consequences.